Wait. So please tell me, like, if you have noticed my recording is not on, please let me know, okay? Otherwise, like doctors who are not attending the live classes will be a disadvantage, right? So let's start. Let's see who is here. Okay. So we'll start from multiple myeloma, right? Okay, so because the multiple myeloma question is repeated on I yeah, November they have repeated. February, I'm not sure about the October, but September they have repeated, and 2025 March also they have repeated it. And the March doctors, please do 2025 March recalls because today we have noticed because I have like ongoing February recall class. Today we have noticed so much questions from 2025 March file as well. Okay, so please go through those 2025 March as well. Okay. Yeah, sure. Yeah, doctor. Yeah, I'm usually uploading my all the videos. Yeah, only I couldn't upload some cardiovascular videos I have done in December 2025, but I will upload those as well. Okay, soon because yeah, I have to download it again from the drive and it will take so much time. So for now, like currently, like when I'm doing a session to like after that day tonight. So as example, after today class tonight, I'm uploading it in the YouTube like that. Okay, so let's discuss about multiple myeloma. So what is multiple myeloma? It's a myeloma is a blood cancer of the plasma cells that are made in the bone marrow. Because bone marrow is found through the body, and myeloma can affect multiple areas at the same time, and the disease is often called multiple myeloma, right? So, what is happening in multiple myeloma? So, what is happening in multiple myeloma, doctors? So, first of all, tell me what type of disease is multiple myeloma? It's a cancer, right? It's a white blood cells cancer, especially in plasma cells, right? Plasma cells. So, what is happening in multiple myeloma, doctors? In multiple myeloma, that means the myeloma cells produce abnormal, right? Abnormal plasma cells, right? Abnormal plasma cells. Yep, myeloma begins when abnormal plasma cells known as myeloma cells start multiplying. Normal plasma cells make different types of antibodies to help the body to fight infection, but abnormal plasma cells make antibody known as paraprotein, monoclonal protein or M protein. These are abnormal one and the usual one are help to protect our body from uh, infections, but in multiple myeloma they have abnormal plasma cells. Because of these abnormal plasma cells they are given abnormal antibodies, right? Abnormal antibodies, and these can cause different features, different problem in our body, right? Yeah. So okay, so let's discuss about it. So you know what is happening in here, right? Yeah. So let's discuss about what are the clinical features. What are the clinical features that we can see in here? 1 minute. So give me example. What are the clinical features that we can see in here? What are the features that we can see in here? Doctors, tell me what are the features that we can see in multiple myeloma? Do you remember the crab? We usually remember it as crab, right? Yeah, crab criteria. So what does mean crab? We have hypercalcemia. C mean hypercalcemia. R mean renal impairment and A mean anemia, B mean bone lesion. So now I am going to explain one by one what is happening here. So C mean hypercalcemia, right? So when there is a hypercalcemia present, what can we see? What can we see in doctors in here? So why there is a hypercalcemia? Why? Why there is hypercalcemia? Why hypercalcemia present, doctors? Because this is happening in myeloma cells, right? These bone marrows are like causing abnormal plasma cells. Because of that, bone breakdown can cause, right? Bone breakdown can cause and release the large number of calcium into the blood, right? Large number of calcium into the blood. Because of that, we can see hypercalcemia. So, because of hypercalcemia, what are the clinical features that we can see in this body, in this multiple myeloma patients? What we can see? Because of high calcium level, patient can have polyuria, constipation, confusion, right? Those kind of features we can see in these patients, right? Okay, so that is what? That is hypercalcemia. C. Then we have renal impairment. So why? Because of why there's renal impairment? Who can tell me what is the cause of renal impairment in these multiple myeloma patients? Why? Renal impairment because why? Do you remember that I just explained? Because of abnormal plasma cells, there is a formation of abnormal antibodies. We call those a paraprotein, right? Paraprotein. Here I'll show it. Okay, so here paraprotein, here paraprotein, and we have free light chains as said. Paraprotein because usual the normal the healthy body plasma cells produce antibodies to fight against the infection, but abnormal plasma cells making abnormal antibodies. You can remember like this. So those are the paraproteins, free light chains, like that. Okay, some free light chains combine together with heavy chains and form paraprotein, and some are freely in our body as free light chains. Okay, so please remember these things. Yeah, here myeloma cells produce antibody known as paraprotein to make a diagnosis of myeloma. Yeah, no need. I'll explain it one by one. Okay, here, like that. Then, because of that, okay, now our in multiple myeloma patient, there's paraprotein and this light chain. So, what is happening here? These excessive light chains, and right, these light chains and paraprotein are what happening what they're doing, they are precipitating renal tubules, right? Renal tubules then can be obstruction, inflammation, and these obstruction, and because of this obstruction, inflammation due to precipitation of these paraprotein and cause the kidney injury, right? Acute kidney injury, and there because of that there can be a renal impairment. Then what else? Because of these light chains, they can see in urine. We can see in these excessive light chains, excessive monoclonal light chains in the urine, and we called it what? We call it Bence-Jones proteins, right? We call it Bence-Jones protein, right? Do you understand? So, what are the Bence-Jones protein, doctors? We call it these light chains as Bence-Jones protein because it's appear in where? Where, doctors? Do you understand? You have to answer. I feel like you are not understanding. Yes. Mm-hmm. Yeah, yeah. Understood, right? Yeah, we can find it in the urine. Right, doctors? Why? What are those things? These are this monoclonal excessive free chains accumulation, right, in urine. Because these are very important when we discuss about the investigations. That's it. I'm explaining one by one. Okay. So what about anemia? What kind of anemia we can see in here, doctors? What kind of anemia? Why anemia here? So here in the bone marrow, in here bone marrow, they have to fill. Mhm. They have to filter these malignant plasma cell, or they have to filter these abnormal plasma cell. Because of that, the hematopoiesis, or the blood cells production is suppressed, right? Blood cells production or hematopoiesis is suppressed. Because of that, we can see the anemia. And this anemia is what kind of anemia? This is normocystic. Here we can see normocystic or macrocytic anemia. We can see normocystic or macrocystic anemia, right? Usually, but mainly we can see the normocystic anemia. Okay, so please remember. And the patient can have fatigue, failure, dyspnea, exertion, like that. Okay, usually normocystic anemia, because they are not affecting due to, not because of due to B12 deficiency or iron deficiency. It's because of due to suppression of hematopoiesis, right? So yeah, like that. Then, why these bone pain and bone fractures can see? Why, doctors? Why this bone pain and bone fractures? Why? Why? Okay, I'm telling the reason. So these malignant plasma cells, these abnormal plasma cells can accumulate in bone marrow, right? We all know that. Then they are releasing cytokines. They are releasing cytokines, and these cytokines activate osteoclast. We all know the clast means the destructive one, right? Digestive one, right? Osteoclast, digestive cells. So they are activating this class and they destroy the bone. Because of that, this bone pain and the bone fractures and bone lesions can occur, right? Because of that. So what we can see in here, in this multiple myeloma, you can see lytic lesions, right? Lytic lesions. Okay, I'll show lytic lesions because of these osteoclast activities. Okay, I'll show you. Usually skull here. Can you see like lytic lesion here? Can you see here? Lytic lesions. Those are the lytic lesions. Then, yeah, bone pain, lytic lesions. Those are the things you should remember. Then we have discussed renal impairment, anemia. Then why this patient is having recurrent infections? Who can tell me why this patient is having recurrent infections, doctors? Because they have abnormal antibodies, right? Like they're good antibodies that used to fight with the normal infections are suppressed, right? Because they are producing abnormal amount of antibodies. Because of that, patient is get what immunosuppressed, right? Because of that, the patient can have recurrent infections, right, doctors? Yeah. Then other than that, patient can have peripheral neuropathy, because these light chains can distribute all over the body, and they can be precipitate in different organs. and they can cause some other problems. And yeah, like that. That's generally um, because I want to explain the mechanism behind it, because that's why I explain. Otherwise, I can just tell me anemia, just can tell like anemia, hypercalcemia, renal impairment, bony pain, but you should know what is happening. Then it will easy to understand and answer the question in the exam, right? So these are the things you should remember. Okay, so here. Okay, so when to suspect multiple myeloma, doctors? When to suspect multiple? Now we are going to discuss about these. Uh, sorry, investigation. So here, when there's a clinical features, we all know bone no back pain, minimal trauma fracture, systemic symptoms like weight loss, fatigue, recurrent infections, and anemia features, and hypercalcemia features, right? So everything are included in here. Then laboratory features, pneumocystic anemia, raised level of globulin serum protein, then raised ESR, hypercalcemia, then renal impairment and proteinuria, Bence-Jones protein, right? Bence-Jones protein. We can see if we are suspecting, if we are comparing these symptoms and signs, laboratory features, everything, we are suspecting multiple myeloma. So, what is the investigation that we should do? So, tell me what is the type of investigation that we can do. Tell me, doctors, if you are suspecting multiple myeloma, what is the initial investigation? What is the best, most appropriate investigation that we can do? You have to answer because you know this. Doctors, where are you? Mm-hmm. Okay, so what do you know about electrophoresis? What do you know about electrophoresis? What do you know about that? What do you know about those things, doctors? What do you know? Okay. Mm-hmm. What about the doctors? Initial serum in electrophoresis. Good. Yeah. So we have. Mm-hmm. We have what? We have serum protein electrophoresis. So serum protein electrophoresis. So what are the things that we can see? What are the things that we are testing in here? In serum protein electrophoresis, what are we checking? We are separating serum protein based on their electrical charge, right? Electrical charge. Mm-hmm. And we are looking for what? M proteins, right? M proteins. Because why in multiple myeloma, there is a overproduction of these monoclonal immunoglobulin, right? Abnormal monoclonal immunoglobulin. Because of that, we can see in this electrophoresis, we can see sharp narrow spike for this M protein, right? Or paraprotein. We call it M protein or paraprotein. Right, doctors? Yeah. Okay, then so what else we can do? So what is UPEP? UPEP mean urine protein electrophoresis, right? Urine protein electrophoresis. We can do serum protein electrophoresis and urine protein electrophoresis. Other than that, we can measure the serum free light chains, right? Serum free light chains. Okay. So before going to treatment and everything, I want to do some questions. Okay, this question is appeared on. They ask about this in not this exact question, but in November they have asked about what is about investigation. But in January, not January, February, they have asked about what type of cells that we can see in multiple myeloma. Okay, So because of that, you have to be make sure about it. So next one, this is my February file. So 60 years old woman present to the GP clinic with 3 months history of fatigue, back pain, recurrent chest infections. She has no significant medical history and does not take any regular medications. On examination, she appears pale, pulse rate is 72, BP 120 by 80, respiratory rate 16, SpO2 98, temperature 36.7, blood test reveal hemoglobin 98, creatinine 130, urine analysis show 2 plus protein. Further urine test revealed protein creatinine ratio 350 and albumin creatinine ratio is 50. Which one of the following is most appropriate investigation? Mm-hmm. Yes. Okay, so let's check here. The answer is serum protein electrophoresis. The patients present with symptoms and laboratory findings suggestive of multiple myeloma. The most appropriate next investigation in is serum protein electrophoresis, which can detect the presence of monoclonal protein or M protein characteristic of multiple myeloma. The clinical picture consistent with myeloma, fatigue, likely due to anemia, back pain due to bone involvement, recurrent infections due to immunodeficiency, anemia or renal impairment, and proteinuria. Notably, there is a disproportionate of high protein creatine ratio compared with the albumin creatine ratio. This discrepancy suggests the presence of non-albumin protein in the urine. So, which is myeloma? Typically monoclonal light chains. That means Bence-Jones protein. Mhm. Okay, so here multiple myeloma can cause proteinuria with disproportionately high protein creatine ratio compared to albumin creatinine ratio due to the presence of monoclonal light chains. Okay, another, yeah, I have, marked that one. It's another question. Okay, here we'll quickly discuss. A 67-year-old man present to the 4-day history of right hip pain. Because I'm discussing this because you need to get the like clinical scenario properly. This is a one clinical scenario that patient can present, and this is another one. Okay, so that's why I'm reading this. The pain came on suddenly while rising from a chair with no history of trauma. He has never experienced similar hip pain before and now require a walk-in aid. His medical history include hypertension, diabetes, and hypothyroidism. His regular medications include metformin, perindopril, and thyroxine. Examination, he appears unwell. Pulse rate is 88, BP 135 by 85, respiratory rate 16, SpO2 98, temperature 36.8. He has severe pain on passive movements of the right hip. Lower limb pulse are present bilaterally and neurological examination is normal. Radiograph shows normal bone density with displaced right femoral neck fracture. Laboratory investigation revealed sodium 135, chloride 105, bicarbonate 25, calcium 2.75. So calcium is increased. Creatinine increased, hemoglobin decrease, MCV is normal. So uh, this is normocystic, normochromic anemia, right? Yeah. All laboratory values were normal 1 year ago. He is up to date on routine health screening. So, which one of the following investigation would be most appropriate to determine the underlying cause? So, it's always first thing first, serum protein electrophoresis. So, please remember. Okay. So, yeah. Here, serum protein electrophoresis is the initial screening test of choice for suspected multiple myeloma. So, yeah, please remember. Okay, one more question. 62-year-old man present to the GP practice clinic with 2 month history of increasing fatigue, 8 kilograms weight loss, and increased urination. He also has dull pain in his arms and legs. He has no pre-existing medical concern and take no regular medications. He is non-smoker and drink about 3 glasses of wine a week. Undergoes regular bowel cancer screening. There is no family history of any cancer. On examination, he looks pale, blood pressure 125 by 90, pulse 90 and temperature 37. The rest of examination is unremarkable. Initial investigation revealed that he is hypercalcemic with decreased parathyroid hormone and normocystic anemia. Which one of the following is most likely to be positive? Calcitonin, BCR-ABL, then CA125, casio-embryonic antigen of serum free light chains. So we all know this is suspect of multiple myeloma and we can see serum light free chains, right? Yeah. So hope you understand it. Okay, so we were discussing about the screening part. We were discussing about screening part, right? So what do you know about the biopsy? What do you know about biopsy? What do you know about biopsy? Are we using bone marrow biopsy in multiple myeloma? Are we use multiple myeloma like bone marrow biopsy in multiple myeloma? Okay, remember. Okay, remember like this. Okay, so usually the multiple myeloma, the confirmatory test. If they ask confirmatory test, it is bone marrow biopsy. But usually we are not doing it because these electrophoresis and other these screening tests are enough to diagnose. But if we like after these screening test and everything, uh, we are we are referring this patient for the hematologist, right? If hematology, then after that hematology, if want more further details or need some other details, the hematologist can do the bone marrow biopsy, but it is not usually doing. But if we need, we have to do it to confirm the disease, right? Confirm the disease. Okay. Otherwise, we are not usually doing bone marrow biopsy in multiple myeloma. Okay. Like if there's something abnormal morphology, like increase very high amount of these plasma cells, like yeah, bone marrow, increase plasma cells in bone marrows, right? So in that case we have to do, but usually it's done by the hematologist, like under hematologist guidance. Usually, as initially we are doing, these are the most common tests that we can do. Actually, like these three together, the sensitivity is very high. Okay, if we are doing these three together, the sensitivity is high. But if they ask what is most appropriate one, always go with serum protein electrophoresis. Okay, so one more thing I have to share, I have to show you. This is RSCGP guideline. Here, investigation by hematologist, bone marrow aspirate and trephine including cytogenic analysis. These are done by the hematologist. Okay, hematologist. And other than that, we can do the imaging, a skeletal survey, whole bodies X-ray, because they can cause like bone destruction and lytic lesions. So we have to identify these fractures and weak bones, everything. Okay, yeah. These are the other things than this screening test. 1 minute. Okay, here. And here, evaluating patients with suspected multiple myeloma involves establishing evidence of monoclonal paraprotein serum electrophoresis immunofixation together with FLC analysis. Okay, we can do these things. And here they have mentioned serum electrophoresis establish the presence of monoclonal band, while immunofixation increased diagnosis sensitivity to 93% and determine the presence of paraprotein. Yeah, like that. And here, the combination of these three tests has diagnostic sensitivity 97 to 98%. Okay, so please remember these points. No, no, doctor, these are my paid group. I'm doing paid classes. So for the recalls, so these file is from my that class. Yeah. We have an ongoing February recall class, and we just finished day three recalls because I'm usually taking 2 days to cover a 1 day recall because we have to go through each topic like that. Okay, like that I'm doing because I have to go through topic as well as I have to go through e-medicine like that. Because of that, it's time taking. Okay, so yeah, so we all know about now the screening and in other investigations. So let's check. Okay, then the like you can go through this one. Let's discuss about the treatment. Okay, here how we should treat this multiple myeloma. Okay, we have diagnosed it and we can do the like, skeletal survey. Other than this electrophoresis, these are the screening tests, right, for multiple myeloma. Then after the treatment, so what is the treatment options? February doctors, tell me what are the treatment options, what are the criteria. Who are in my recall classes we have discussed, tell me, you should remember. Where are those doctors? Mm-hmm. Okay, yeah, let's discuss. Okay, here. The symptomatic myeloma usually require immediate treatment for those younger than 65 years of age or those aged 65 to 70 with few comorbidities are eligible for autologous stem cell transplantation. So, who are eligible for stem cell transplant? Tell me who are eligible for that. Patients under 65 or patients who are at 65 to 70 but with a very limited amount of comorbidities, like less comorbidities, like others are not eligible, right? Yeah, above 70 not eligible. And here you should remember patients typically receive 3 to 6 cycles of induction treatment aiming to achieve a complete or near complete response prior to their transplant. Okay, here. Okay, now patient is okay. Our patient is 63 and eligible for transplant. Okay, transplant. The patient is eligible for that. And before transplant, we have to give 6 cycles of induction treatment. So, what is induction treatment? Induction treatment have three components. So, these induction treatment have three components. So, what are those, doctors? Tell me. One, two, three. What are those? What are those? It has steroid therapy. Steroid, then chemotherapy, cytotoxic chemotherapy, and we have immunomodulatory therapy. Immunomodulatory therapy. So these three together we called induction therapy. We call it induction therapy. Here, can you see? Okay. Now, here, the best result appear to be achieved with a combination of steroid, cytotoxic chemotherapy, and novel immunomodulatory agents. Right? So the O, it immunomodulate agents O, not and O proteasome inhibitors. Right? So we have to, if the patient is eligible, we have to give induction therapy for 3 to 6 cycles. Then we can do the transplant. Okay, here they have mentioned given the This chart as well, newly diagnosed multiple myeloma, transplant eligible or not. If it is eligible, induction regime typically used in combination therapy. So then disease assessment, at least partial response achieved. So after that, okay, we have started this combination therapy, or we call it induction regime. And uh, after we have to assess the disease. Assess the disease. So what we are assessing? We are assessing the response. If the patient is at least present partial response, if it is yes, then we can go with the transplant. If it is not, we have to do the salvage induction regime inducing novel agent. Again, we have to introduce other agents and induction agent, and we can continue. Then again, analyze the partial response. If achieved, we can do the transplant. Okay, then after transplant, we can do the maintenance therapy. After salvage induction also, there's no response is achieved, like at least half response should be 50% response should be achieved. It's still not achieved, then again we have to salvage therapy with a new alternative. We have to change the drug, and we have to change the drug and replace with all the drug, and we have to try until they are getting like 50% of a response, right? Like that. Okay, if the patient is not eligible for transplantation, we can use combination therapy with choice of novel or traditional agents. Hope you understand everything about multiple myeloma. That's all for multiple myeloma. Hope you understand everything, doctors. Do you have any other question? Okay. Let's do this month question. Okay, this is the February question. 60-year-old man has pathological rib fracture. He also complains of recurrent infection, BMA or bone marrow aspiration done, labs calcium 3.9 increase more than 2.7, right? And ALP 127. What type of cells would be found in abundance of marrow smear? What type of cells, doctors? So we can see plasma cells here. Okay, here. Uh, it is also from therapeutic guideline. Bone marrow aspirate shows the increased number of plasma cells here. These are the plasma cells, including large and immature forms here. These are the, you can see these arrows, plasma cells. And this is the numerical multiple myeloma suspected next step. So we have to do the serum electrophoresis, right? Hope you understand it. So we have done questions. These are the questions in multiple myeloma. Yeah. So hope you understand everything. Do you have any questions? You can just ask me. Or we can take a small break. Okay, we'll take a small break because you don't have any questions.